So the CANDOR study is being presented as a late-breaking abstract at ASH this year. And this is a large randomized phase 3 study in 1 to 3 prior lines of treatment, relapsed refractory multiple myeloma. And the two arms of the study are Carfilzomib, Daratumumab, Dexamethasone, and is being compared with Carfilzomib and Dexamethasone. So as you can see that this is an immunomodulatory drug-free regimen, and the rationale for the trial is since we have 6 different combinations to treat patients with early relapse disease, 4 of them contain lenalidomide. So what about those patients who are either on len maintenance or coming off of a len-based regimen and relapsing? Because we don't have data for those patients and need an IMiD-free regimen. So this particular trial was a 2-to-1 randomization, which means that for every patient getting KD, 2 patients were randomized to receive Dara with KD. And the treatment on each of these arms was was continuous to relapse, progression, or intolerance. The median PFS was the primary endpoint. Secondary endpoints included overall response rate, MRD negative CR rate at 12 months, overall survival, safety, all of those things were included. And after a median follow-up of 17 months, the primary endpoint of the study was reached. The median PFS on the standard of care arm was 15.8 months, and that in the experimental arm with the 3 drugs hadn't been reached with a hazard ratio of 0.63. The overall response rate was also higher, 84% versus 73%. And the MRD negative CR rates at 12 months were 12.5% versus 1.3%. And at 17 months of follow-up, there's no difference between the median overall survival between the 2 arms. From a safety standpoint, numerically, the grade 3 or higher AEs are higher in the 3-drug combination compared to the 2-drug combination. Primarily, infections and cardiovascular events were seen, but no discontinuations were seen because of the serious adverse events. I do want to mention that that for the infection risk, it was higher in the 3-drug combination, but interestingly, the cardiac failure rate of grade 3 or higher appeared to be lower in the 3-drug combination. I believe 4% versus 8.5%. So even the 8.5% is comparable or lower than what has been reported in the past, but we don't know how to explain these results. In terms of fatal treatment emergent adverse events, there were 5 events in the 3-drug arm compared to none in the KD arm. And 4 of those 5 events were infections. And we've had this theme at ASH where a lot of the treatments that myeloma patients are receiving have higher incidence of infections, especially when you're looking at the IOs. So, I think, we are looking at how to predict patients who may have infections, but prophylaxing patients and thinking about how best to prevent infections from happening in these patients, or the use of IVIG if they have hypogammaglobulinemia would be important. So taking together the safety and efficacy data, I think DKD would be a very good option for patients, especially in that pre-specified group of len-exposed, len-refractory patients, where it seems to be benefit as well as it has in other subgroups.